When we're thinking about CAR T therapy in a third-line setting, we know that patient selection is really important. We want to try and get the CAR Ts infused as quickly as possible, so we need to be aware that they've relapsed and arrange early apheresis and reinfusion as soon as manufacture is complete. We also know that debulking during the bridging phase is important. So we want to take the patient into CAR T with as minimal tumour burden as possible, so total metabolic tumour volume as low as possible. And we tend to do that with either further chemoimmunotherapy, or we're also using more and more radiotherapy bridging. And this can be important in chemo-refractory patients. It can be important in potentially increasing antigen exposure and improving efficacy of CAR T. So we are starting to use a lot more radiotherapy. And I think that something else that may become quite interesting is that now that there is a license for polatuzumab in the frontline setting, it may be that we use less polatuzumab in combination with rituximab bendamustine as a bridging strategy, which up until recently was certainly our chemoimmunotherapy standard bridging approach. So we really want to be careful with patient selection. We want to be debulking the patient as effectively as possible.